I am Professor Dr. Aniruddha Ghosh, and I will present them how to manage atopic dermatitis. Now, what will I discuss? How to diagnose atopic dermatitis. I'll talk something of the history, how to take a proper history, the clinical examination, and the laboratory investigations. Coming to the history part, only the history of the patient is not sufficient. The family history is also important. Sometimes the family history can stretch to your grandparents. তো অনেক সময় পেশেন্টরা এসে বলে যে আমার বাচ্চার এটা হয়ে আছে, কী করে হলো, আমাদের নেই, আমার নেই, ওর বাবার নেই, কী করে হলো। তো আমি দাদু দিদিমার হিস্ট্রি নিই, দে প্রেজেন্ট উইথ বঙ্কেল অ্যাস্থমা অর সাম অ্যালার্জিক, অ্যান্ড আই টেল দেম টু প্যাসিফাই টু পেশেন্ট। আমি বলি যে এটা তোমার দিদিমা, দাদু ঠাকুরদা আশীর্বাদ হিসেবে দিয়ে গেছে, and that pacifies the parents ki ha, this is something that is coming to from the grandparents, so I have to bear with it. Because atopic dermatitis, the parents are very, very much tensed about how the kid will. Because if you see some serious atopic dermatitis patients, they are not able to go to school. The other kids avoid them because they are continuously scratching. The other kids avoid them. The parents tell the kids not to mix with that kid because they think it is something infectious. And the babies suffer from not only psychological trauma, they obviously from the disease itself, the severity of the disease at certain times of the year. So we have to properly counsel the patient how to go about it. And obviously we have to take the history of precipitation of itching from sweating or due to emotional disturbance. And obviously we have to ask for a visual scale. Now, clinical examination, as we all know, for the babies, we should examine the extensions where they're due to friction when the baby is crawling. For the children, it is the flexors, and for the adult, the entire body, for the lichenification and anything else. Now, we sometimes face certain patients who we know that it is atopic dermatitis. We see, but all the history, all the points of Hanifan-Rajka criteria is not fulfilling. Then the new term has come up as atopic diathesis, where all the criteria is not fulfilling, and but we know that the diagnosis is something close to atopic dermatitis, and in that the severity is not so severe, but the typical size or sometimes the itching, all these are very much similar to atopic dermatitis. And obviously the presence of multiple eczematous pruritic lesions and the dry skin. Now, laboratory investigations, normally we don't do, but for certain patients, we have to do a serum IgA level, which is not always elevated, but in 80% of patients, it is elevated. In 20 to 30%, it is normal. We can do specific IgE tests like RAST, and the amount of IgE is proportional to the amount of the radioactivity. The 100% positive RAST is seen in only in respiratory atopy. In food atopy, it is around 88% positive. Other tests include ELISA and PRIST. Now, this is something the parents will always ask you. Is it going to last forever? Will my child have this disease severity all throughout the life? And this is something you have to address when you are first seeing the patient. And the treatment, what we will talk, will be divided into first line of treatment, the second line, and the third line, and the newer therapies that is coming, and some of them down the line. Now, general advice, the reduction of the triggering factors, how we'll talk about something about the topical, the bathing and the emollients, the corticosteroids, the tar. We will talk something about the systemic and the others things like antihistaminics and the antibiotics. Now, first the general advice, we should educate the patient, even the parents, that about atopic and its manifestations. Earlier, it was thought that the atopic dermatitis will go off by the age of 14 or when the patient goes to adolescence. Nowadays, the concept totally changed. It is going till the adulthood. Yes, the severity may decrease, but most of the atopy is carried out lifelong. Sometimes we do see nowadays lot of patients with adult onset atopic dermatitis also. Now, we should ask the patient to avoid some triggering factors and the aggravating food allergies. These are problematic because in the allergen test that we do, if you see, go through the Andrews and all, it is given probably that if you do the allergen test, if 80 people is positive to a certain food allergy, out of 80, 76 are false positive. Only 4 people have proper allergy to that certain food particle. So what is the use of the allergen test? The negative value is very important. All the foods that have been eliminated, you can safely keep to the kid. But all the foods that is given positive, you have to be a little bit careful, but you shouldn't completely avoid it. You should check whether any food, particularly 1 or 2 foods, is increasing the allergy or not. It doesn't mean that every food article has to be avoided. Because all the foods that we avoided is given, like eggs and all, is very essential for the growth of the baby. Now, obviously, wear cotton garments. In the winter, wear a good cotton cloth inside and then wear the woolen clothes because they have very much sensitive to woolen garments. Avoid house dust mites as much as possible and reduce stress. Ask the baby not to, or the kid not to go out and play during the higher activity of the atopic dermatitis. Now, bathing and emollient, it is very important. Why? We ask the patient to bath in lukewarm water. Now, we have to explain to the parents what is lukewarm water because sometimes the overzealous parents, they give bath in a scorching water bath. The more hot the water, probably the baby will get better. No, that actually damages the skin much more and that will worsen the atopic dermatitis. We should properly counsel the patient what is lukewarm water and how much. Sometimes the parents will give 2-3 baths in a day. No, 1 bath is enough, not more than 10 minutes. That is the dictum, not more than 10 minutes in lukewarm water. And obviously, with coconut oil is one of the most cheapest and the best emollient. Before the bath, some people say that give before the bath, but I think personally giving oil before the bath is not as effective as putting oil during the bath. Ask the patient to take a normal bath, then put coconut oil all over the body, give some more bath so that extra oil flows away, and then pat dry. That is very important. Pat dry, don't rub the skin, pat dry, and apply the emollient within 10 minutes of the bath. That will give a very good moisturizing effect. Now, we know what are the types of moisturizers we have. We have the humectants and the emollients. The humectants are hygroscopic in nature, but the problem with humectants is that if the atmosphere is very dry, it will attract moisture from the skin itself. Whereas emollients are occlusive agents that make the skin soft and pliable and they increase the hydration of the stratum corneum. We have a lot of emollients nowadays with cetyl alcohol and oatmeal. Oatmeal is very good moisturizer in case of atopic dermatitis. Now, one of the most important things that we say to the patient, moisturize, moisturize, moisturize. As much as you moisturize the baby in atopic dermatitis, the lesions will decrease. So, short bath in lukewarm water, immunizer applied immediately after the towel drying, and improve the hydration and retain the immunity for a longer time. Now, sometimes in case of severe atopic dermatitis, we ask the patient to give some compressors, the occlusive dressings and the compressor bandages. And there are 2 types of compressors. They are the saline compressors and the medicated compressors, and they act as a soothing agent. It's not always given all over the body, but mainly in those resistant areas or the really damaged part of the skin. And it reduces the vasodilatation and the inflammation removes the dirt and debris and they keep the lesion clean. Now coming to a boon for most of us, that is the topical corticosteroids. Remember, topical corticosteroids for children, you have to be extra careful. We should not always give high potent corticosteroids because in the children, their skin vascularity is very much there and they are more prone for the side effects. Now, as ma'am had talked in the first lecture, if you give too much of high potent steroid in the children, we will land on stria, which was in the first lecture. So give a corticosteroid and remember, it should be not too less potent, it should be as potent so that the severity decreases within 7 to 10 days. Short term of topical steroids. And one of the most important, if the dictum is the body surface area is involved more than 10%, it's better to give a short term of oral steroids than to give a all body corticosteroids, local topical corticosteroids. If it is more than 20%, 10 to 20% of the body surface area involved, better give a short-term oral steroids that will decrease the severity. The corticosteroids acts in 4 major ways: the anti-inflammatory role, the anti-proliferative action, the vasoconstrictive action, and the immunosuppressive action. The strength and severity and the mode is very important. Now for the eyelids, face, you can give 2 or 3 corticosteroids depending on the areas. In the body you give something as strong as gomedazole. In the eyelids you give as low as hydrocortisone, because eyelids, face, groin, axilla, inner thighs, these are sensitive areas. Give low potent steroids. Steroids can be given to children less than 1 year, but for short duration, 3 to 7 days. And before they used to say twice daily application. Recent studies have shown steroids once a day application is equivalent to twice a day application, and it will decrease the side effects. So once a day application of steroids is more than enough. We have steroids in ointments, creams, and lotions. We all know where to give ointments, where to give creams, and where to give lotions. And this is very important, the fingertip unit. Obviously, if you don't tell the patient, if you don't tell the parents how much to apply, they will apply too much. We have seen patients who applied thick creams all over the body and kept it. It is wastage of the cream. Not only is wastage of the cream, it will increase the side effects. Because nowadays we know that Staph aureus is a super antigen. We will land up in secondary infections in atopic dermatitis if we give too much of too much of steroid cream. Once daily treatment in the evening and morning after the emollients, or you can increase the application of emollients, not the steroid. Now, it can cause side effects if abused, and the complications related to systemic absorption are rare, but local side effects we have to keep in mind are about permanent telangiectasias in the cheeks of the babies, striae in the breast, abdomen and thighs in the adolescents. And particular care has to be taken around the eyes as glaucoma may be induced. Now, systemic treatment is mainly given when there is widespread eczema, and there are cases of erythroderma, and in frequent relapses of the atopic dermatitis, patients with significant compromise in the quality of life. When the child is not able to go to school, not able to play with the kids, is having a lot of psychological trauma, then we go for systemic treatment. Now, systemic treatment, obviously antihistaminic is something we always give, and because we have to decrease the itching. H1 receptor antagonists are predominant for the sedative effect. In the night, morning, we'll give something, H2, second generation. Used in short courses, 10 to 14 days, and they can cause drowsiness. That's why we give the second generation antihistaminics for the morning. Now, one of the recent studies have shown that the H1 receptor, the sedative antihistaminics causes induced sleep, and that is non-REM sleep, and that's why it's like almost like alcohol-induced sleep. So it is better to be avoided. So always give second generation. First generation is now slowly phased out. Now, antibiotics is given in exudation and pustule formation, which implies there is staphylococcal infection. Oral fluxolone or erythromycin is more than enough. And sometimes when the patient fails in the first line of management, we have to go for the second line of management. And within the second line of treatment, we have intensive topical treatment, we have the wet wrap technique, the immunomodulatory creams, the allergy management, foods, inhalers, and contact allergy. Intensive topical treatment, the strength of the topical steroids can be increased, and for a very short period. The wet wrap technique that we don't always practice here, but it is practiced in the Western countries, where the 2 layers of absorbent tubular bands are applied to the skin. The inner layer is pre-soaked in warm water and the outer layer is dry. The baby is wrapped in that, but a low potent potassium is applied to the skin before the dressing, and the dressing is changed every 12 years. It's very, very cumbersome for the baby to have a wet wrap therapy, but it may be needed in case of very, very severe atopic dermatitis. We have something of topical immunomodulators nowadays, like tacrolimus and pimecrolimus. 0.1% ointment up to 12 months in children and 6 to 12 years in the children. It is effective in mild to moderate atopic dermatitis. Side effects are minimal burning sensation, and we can decrease that by keeping the tacrolimus ointment in the fridge half an hour before application. 0.1% for the adults, 0.03% for babies, not for the children, for the babies. Pimecrolimus 1% cream to apply twice daily. The side effects are transient, burning and pruritus, and should be avoided below 2 years. Other third-line therapies like the phototherapy, the oral immunosuppressants, desensitization, and the immunotherapy. The phototherapy, it works in 3 major mechanisms. The first effect on the subtle soluble mediators of the skin. It induces the IL-10 and PGE2 inflammatory and immunosuppressive action. In the second way, it works on the expression of the suppress-associated molecules, and it also induces the apoptosis. The UVA is mainly given in acute severe atopic dermatitis and is restricted to 10 to 15 exposures. The narrowband UVB is used for chronic atopic dermatitis, and the side effects are erythema, sunburn, and nausea. Now, this is a wonderful drug that we have, cyclosporine, 3 to 5 milligram per kg body weight in 2 divided dose. Now, there are a lot of doctors who start with 3 and go up to 5. My time is, I think, 16. We have time left, right? So, some people do go from 5 milligram per kg body weight and decrease it to from there, and some people go from 3 to updose it. Now, updosing or downdosing is up to you, but what I prefer is something in between 4 milligram per kg body weight, and then because then I have in my hand, if the patient is responding, I can go taper it down. If it is not responding, I can taper it up. So I do that in my private practice. It's up to you. The dose can be tapered every week and can be stopped within 3 to 6 months. And the adverse event, we have to very much concerned about the renal toxicity, the hypertension, the hypertrichosis, the gingival hyperplasia, and others. Azathioprine is a much safer drug. 1 milligram to 2.5 milligram is the dose for kg body weight per day for 3 to 6 months. The GI effects are the main side effects. The hepatotoxicity, the bone marrow suppression can occur. Other drugs, we have MMF, the intravenous immunoglobulin G, the fatty acids, some Chinese herbal medicine, interferon gamma. This is very important now. The neotherapies. What are the topical neotherapies that we have? We have crisaborole, very good molecule. It was in America for a long time. Now in India, it is still there. I don't know whether it's in Bangladesh. Probably soon you will have it. It is good molecule. It is almost better than tacrolimus, but the problem is it's very costly and it causes the same irritation. What the thing we face with tacrolimus irritation, crisaborole has also the same irritation. But a new molecule that we can try for small areas. The only JAK inhibitor, topical JAK inhibitor that has been FDA approved is ruxolitinib. It targets the JAK-STAT pathway and reduces inflammation and itching. We have the tapinarof, which is a topical aryl hydrocarbon receptor modulator and anti-inflammatory effects used for mild to moderate atopic dermatitis. We have the delgocitinib, which blocks the activation of JAK-STAT signaling pathway. It has shown promising results, especially in the chronic atopic dermatitis. Now coming to the systemic, we have few systemic drugs. The lebrikizumab, which works on the IL-13, it is cytokine central to atopic dermatitis inflammation, approved for moderate to severe atopic dermatitis. Age-old molecule, the dupilumab, but very costly. But newer biologics like talquetamab is expanding the horizon of the IL-13. We have the rocatinlimab, which is a OX40 receptor, targets the OX40 receptor on T cells, reducing immune overactivation and shows sustained efficacy even after stopping the treatment. We have the upadacitinib and abrocitinib. Abrocitinib is now recently launched in India. They are the oral JAK inhibitors, effective for moderate to severe atopic dermatitis, especially in patients unresponsive to dupilumab. Obviously, we have the tofacitinib. Tofacitinib is not approved by FDA for atopic dermatitis, but if you go to the literature of tofacitinib, the disease it is maximum studied is atopic dermatitis. So you can safely give topical tofacitinib in atopic dermatitis. Works well. I have seen it. It works well in resistant cases, but it is not yet FDA approved, probably because we have the costlier molecules that has to be sold, like dupilumab. And these JAK inhibitors, they offer quick relief from itch and durable skin. Now, counseling and psychotherapy has a big role in treating the atopic dermatitis. We have to address the stress. We have to counsel the parents if the patient is a child for do's and don'ts that lead to a stressless life. We have to show proper empathy towards the child, and we have to listen to the parents, because the parents are very much stressed about the condition of the child. They don't see their child having a normal life. The quality of life is very much hampered, and that's why we have to talk to the parent, give them time in the clinic, listen to their problems. We have to expose of the skin to allergy and the irritant compounds. And coming to the summary, it is a chronic itching condition. We have the 3 phases. We should diagnose it by the major and the minor criteria. General advice of psychotherapy plays an important role. Thank you.